Welcome to It's Your Case, presented by vetct.com. I'm Christina Meerhof, your radiologist on demand for this week. Today's example is a 1-year-old male neutered Australian Shepherd with retching and vomitus. Once you have reviewed the radiographs using your systematic approach, then you're ready to watch this video. Now I will highlight the most important findings for these radiographs. We will start with the right lateral and the VD projection. The abdominal detail is good. The ventral liver margins can be nicely delineated. The liver does not extend over the caudal rib cage. The spleen is visible here in the right lateral projection, and the splenic head caudal to the gastric fundus in the VD projection. A moderate amount of gas and granular material is present in the stomach, just here. The gastric axis is normal. Large amounts of unformed granular material are present in the colon, so this is the descending colon, and then the transverse colon probably turns somewhere here. And in the VD projection, it's usually easier to see. This is the descending colon and the transverse colon and the ascending colon. And this material might be located in the cecum, but it's difficult to say only from this view. I don't have the impression that this granular material is present in small intestines in this projection, but to be honest, this could be cecum, but I cannot exclude for sure that this is not a dilated small intestinal loop. There are 2 small intestinal loops that are mildly dilated, rather located in the dorsal abdomen and probably on the left side. And these loops are nicely seen in the left lateral projection as mildly dilated small intestines, parallel oriented in this view, and with no signs of peristalsis, at least in these short segments. Other small intestinal loops have a rather, I would say, mild to moderate gas filling, and there are signs for peristalsis indicated by varying diameter of the small intestines. Other small intestines are present in the caudal abdomen, which are either empty or contain small amounts of soft tissue opaque material. So my conclusion for these radiographs is a mild segmental dilation of small intestines and rather unformed material in the colon. So these 2 small intestinal loops, they are mildly dilated and they have reduced signs of peristalsis. This is not entirely normal, but as there is no significant dilation of small intestines present, so this is defined as small intestinal diameter exceeding 1.6 times the mid-body depth of L5. So if we compare to the depth of L5, this is slightly larger, but not more than 1.6 times. Therefore, there's no true differentiation possible between 2 populations of small intestines. So this is not a mechanical ileus. The visibility of the small intestines is reduced by this large amount of fecal material in the colon. So if the patient is clinically stable, you could perform follow-up radiographs after 12 hours of fasting. And the patient should also have emptied the colon by then. Or in case the patient is unstable and continues to vomit frequently, an ultrasound of the abdomen is recommended to exclude the development of an ileus and to screen for further causes of vomitus, for example, pancreatitis. Be sure to review the full report associated with this case. Thanks for listening, and remember, it's your case. So post your questions on social media.